Yes, visible.
Okay, okay. So, yeah, I think we'll start with the first OSCE. Uh, so these are the questions. I think people can enter their answers in the chat box. I'll wait for 2 minutes for you to read and put the answers in the chat box. Then I'll show all the answers one by one. So first is what are the stages of lactation? Second, which is the hormone responsible for increase in the breast size? Third is which is the hormone responsible for lobular development of the breast? Fourth, what happens during the stages of lactogenesis 1 and 2? Next is what happens in galactopoiesis, and lastly, what happens in galactokinesis. Okay, I think I'll go ahead with the answers. So the stages of lactation, they are mammogenesis, lactogenesis 1 and 2. Third is galactopoiesis. Fourth is galactokinesis. And fifth is weaning and involution. Uh, Estrogen is responsible for increase in the size of the breast, whereas it is progesterone which facilitates the lobular development of the breast. So lactogenesis one, it usually occurs during pregnancy, and there is differentiation of the mammary epithelial cells into lactocytes. Okay, so basically the epithelial cells, they get differentiated into lactocytes that have the ability to produce milk. And second stage is lactogenesis two, which occurs postpartum in the first week, and there is secretory activation of the lactocytes. That is, the milk starts coming in. Next is what was galactopoiesis. So galactopoiesis is nothing but the maintenance of the milk secretion, and the hormones responsible for it are prolactin and feedback inhibitor of lactation. Okay, and galactokinesis is actual ejection of the milk, which occurs under the influence of oxytocin. Right. So should we move to the second one? Okay. So it is about the RBSK program. So expand RBSK. What are the 4Ds which are covered under the RBSK scheme? Uh, where is the screening done in 4 different age group categories for RBSK? Uh, when is the pulse oximetry screening done? And when is the screening considered as passed? The pulse oximetry screening, when is it considered passed? And I'll wait for 2 minutes for you to come up with the answers. I don't see many answers, right? Uh, Somebody has written 3Ds in the chat box. One more D. So I'll go with the answers. Yeah. So RBSK stands for Rashtriya Bal Swasthya Karyakram. The 4Ds are defect, deficiency, diseases, and developmental delays. Okay. So what is the point of or where is the screening actually being done? So for newborn, there are two areas where screening would be done. One is facility-based screening, which is done in all the public health facilities, that is inside the hospitals. And next is a community-based screening, which is done at the home through the ASHA workers. Then for children between 6 weeks to 6 years, the screening is done at Anganwadi centers by mobile health teams at least twice a year. And for children between 6 years to 18 years of age, the screening is done at block level, that is by school health visits. Okay. Pulse oximetry screening, it is done, ideally it should be done after 24 hours, at 24 hours or after that. But if the baby is being discharged, it can be done prior to the discharge. Just prior to the discharge, it has to be done. Okay, and when do you consider it pass? When the right hand and foot SpO2 is more than or equal to 95%, and the SpO2 difference between the two is less than 3%. Okay, so then coming to the third question. Uh, Regarding the Pierre-Robin sequence, so what is the triad of Pierre-Robin sequence? Mention the techniques of feeding a baby with cleft palate. Um, if the child has a median cleft lip, what should we rule out? What are the advantages of a Haberman feeder? And mention the surgical techniques of treating a Pierre-Robin sequence. So I'll wait for 2 minutes again for you to put up the answers. Yeah, so there are some people coming up with the first answer. Yes. Okay. Okay. I'll go with the answers. Yeah. So the answer to the first question is, it is a triad of micropnea with glossoptosis and cleft palate, all three leading together to airway obstruction. Okay, the different feeding techniques. There are some special named feeders like a Mead Johnson cleft palate feeder or a Haberman feeder, and there's one technique called the lact aid technique. I'll show you the picture in the next slide. So they can be used for feeding. Okay. If there is a median cleft lip, we should look for other associated craniofacial abnormalities and hypoglycemia or other features of some growth hormone deficiency, which may be associated with pituitary hypoplasia. Okay, Haberman feeder, basically, what is the advantage is it has got a long nipple and it can be, compressed just by the pressure of the gum and the tongue. So even if the child is not able to press it with the help of his palate, he can draw milk just by the pressure of his tongue and gum. So that way it helps in feeding. And also the surgical techniques which may be used are a tongue lip adhesion, or sometimes distraction osteogenesis, or last option is tracheostomy to bypass the upper airway. Okay, so these are the various feeders which so the one which you see down in the C part is your Haberman feeder. Okay, this is the Haberman feeder, and this is a Mead Johnson feeder. Okay, and this the picture is not very clear, but they are showing the lact aid technique. Okay, and so here is a bag that is filled with milk. The child is allowed to suck at the breast, and because of negative pressure, he is able to draw in milk from the bag. Okay. So coming to the fourth question, regarding the 2022 AAP guidelines for neonatal hyperbilirubinemia. So what were the neurotoxicity risk factors which were mentioned in the guideline in the year 2022? There was one new terminology which they had introduced in that guideline, that was about the escalation of care strategy. So when do we consider the escalation of care strategy? What basically we do in that escalation of care? What are the components of the bind score? And lastly, what are the four classical hallmarks of chronic bilirubin encephalopathy? I'll wait for 2 minutes for you to come up with the answers in the chat box. RH incompatibility, hemolytic disease, mostly the same. Low albumin is a risk factor. Yes. Acidosis, they haven't given. Neurotoxicity risk factor. Acidosis is not there. So I'll go ahead with the answers. Yeah. So the neurotoxicity risk factors are gestational age less than 38 weeks, and the risk increases with each decreasing gestational age. Okay, so the risk will be higher for 37 weeker than I mean the risk will be more for a 36 weeker as compared to 37, and again more for a 35 weeker as compared to 36 weeks. So with each decreasing gestation, the risk increases. Second is an albumin less than 3, isoimmune hemolytic disease or G6PD deficiency, sepsis, or significant clinical instability in the last 24 hours. Escalation of care, it actually refers to intensive care that some of the babies who are having a rapidly increasing bilirubin would need so as to prevent an exchange transfusion. And usually the threshold for this escalation of care is 2 milligram per deciliter. Serum bilirubin less than 2 milligram per deciliter below the threshold for exchange transfusion at that postnatal age. Okay, so at 96 hours, suppose the cutoff for exchange transfusion is somewhere around 24 or 25. The cutoff for escalation of care would be around 23. Okay, so 2 milligram per deciliter below that exchange transfusion threshold. Uh, so how do we manage such babies who need escalation of care? What do we do in this? We shift such babies to NICU and start on intensive phototherapy. We ensure good hydration and send the investigations, baseline investigations, to look for a fall in HB or a rapidly increasing bilirubin or cross match if at all needed. We keep ready. And after intensive phototherapy and hydration, maybe after 2 hours, we have to repeat the bilirubin. If still it is rising, we have to go for exchange transfusion. If it has started to decrease, maybe we can continue with intensive phototherapy. Okay, then components of Bayern score. There are three components. First is the mental status, second is the muscle tone, and third is the cry pattern. Okay, and I mean, there are three scores for each of them. So maximum score of 9. Okay, and the components of this would be upward gaze palsy with sensory neural hearing loss and chorioathetoid CP and dental enamel hypoplasia. Okay, for chronic bilirubin encephalopathy. Okay, so then coming to the fifth question. Okay, this drug that is enoxaparin or low molecular weight heparin. When is it used in the newborns? What is the route of administration? What is the recommended dose in the neonates? What are the advantages of this drug over unfractioned heparin? And what is the antidote? Yeah, so thrombosis. Okay. No, it is given. Okay, we prefer to give it subcute, not IM. Okay, I think I'll go ahead with the answers if there are no answers in the chat box. Yeah. Yeah. So the indications are any thrombotic conditions in the newborn, a neonatal stroke. Okay. And the route of administration is subcutaneous. The dose is 1.5 mg per kg per dose, 12 hourly. So, what is the advantage over unfractionated heparin is it has a greater bioavailability when given subcutaneously, has a longer anticoagulant effect, and requires minimal laboratory monitoring. That is less monitoring of the factor 10A levels, which we need to do more frequently with heparin, and lesser need for dose adjustment. Okay, and the antidote is protamine sulfate. Okay. Then, yeah. So this is a clinical scenario or a clinical case. So here is a term baby who was delivered by vaginal delivery to a primigravida mother, and there was smooth perinatal transition. He was shifted to the mother side and taking feeds well. But suddenly on day 3 of life, there were recurrent intractable seizures. Okay, and when the child was brought to the NICU, he was almost comatose, and the pupils were dilated, non-reactive to light. And in the initial investigations which were sent, we found that CBC showed anemia with severe thrombocytopenia. Platelet count was 22,000. This was in a child who was totally well before this. Okay, first 2 days he was totally well. He was feeding well with the mother, and sepsis workup was done, which was normal. Workup for inborn error of metabolism was also done. That was also normal. And finally, to look for the cause of the child being comatose and recurrent intractable seizures, a CT brain was done, and this was the finding we got on CT brain. Okay, so this is the picture of CT brain which we got. Okay, so in this scenario, what is the most likely diagnosis? How do we confirm the diagnosis? What is the likely pathophysiology of that diagnosis? And what is the possible management? And what advice should you give to the parents for subsequent pregnancies? Just show you the case again. What could be the diagnosis here? Yeah, correct. So sudden onset of this thing seizures with massive intracranial bleed. Okay. So what CT is showing is a massive intracranial bleed. Massive intracranial bleed in an otherwise well child associated with thrombocytopenia. The first thing which should come to your mind is neonatal alloimmune thrombocytopenia, right? Okay. What could be the pathophysiology for it? And how do you confirm the diagnosis? Yeah. So I think I'll go ahead with the answers. So as you rightly said, it is neonatal alloimmune thrombocytopenia. Uh, how to confirm the diagnosis? We need to go for HPA typing, that is human platelet antigen typing of the mother, father, and the baby, so as to establish an incompatibility between them. What is the pathophysiology? Usually, what happens is there is platelet antigen incompatibility between the mother and the baby. Okay, and what happens is because of this incompatibility, there is allo antibody formation in the mother. These allo antibodies are actively transferred across the placenta, and they cause destruction of the fetal and neonatal platelets, leading to thrombocytopenia and uh, may lead to intracranial bleeds. Okay. So how do you manage this case? There's no definitive treatment, but if there is severe risk of intracranial bleed, maybe we can go for platelet transfusion with a target of maintaining the platelet levels above 50,000. IVIG and steroids can be used. Okay, and how do you counsel the parents for subsequent pregnancies? So usually for subsequent pregnancies, what we advise is there should be fetal genotyping in the next pregnancy. And once that has been done and we establish that there is incompatibility in this pregnancy also, then in that case, IVIG and steroids can be started for the mother right from the antenatal period. Okay, so IVIG usually it is started around 20 weeks of gestation. Once a week, IVIG is given to the mother, and also along with that, she is started on steroids, which she has to take daily. Okay, and usually delivery is then planned somewhere around 36 weeks of gestation. Okay, so coming to the next question. This is again a case-based this thing. So here is a term AGA, appropriate for gestational age, male child, born of a second degree consanguineous marriage to a G3 P1 L1 A1 mother. at 12 hours of life, there was an ecchymosis, as you could see here in this picture. There is an ecchymosis which developed at 12 hours of life on the lateral aspect of the shoulder. There was no history of trauma, but within a few hours, such similar patches they started appearing on the entire body at multiple sites. Okay, and these patches they later had blackening and skin necrosis, as you could see in the picture down. Okay, there was blackening of the skin and some skin necrosis was there. When investigations were done, we found that the sepsis screen was normal, the blood culture was sterile, but the baby had thrombocytopenia with a deranged coagulation profile, and there was low value of serum protein C and normal protein S antithrombin 3 levels. Okay, so with this background in mind, these are the questions that what is the diagnosis? What are the points that favor a genetic etiology in this case? Uh, Again, how to confirm the diagnosis, and lastly, what is the management? What could be the diagnosis? Looking at the case, the child was well in the first 12 hours. Suddenly, there was a patch ecchymosis which developed. Okay, and then there were multiple ecchymosis over the rest entire body associated with thrombocytopenia and low levels of protein C with a normal uh, protein S and antithrombin 3 levels. What could be the possible diagnosis? Think there are no answers. I'll go ahead with the answer discussion. Yeah. So the diagnosis is neonatal purpura fulminans. Okay, and the uh, factors which point toward genetic etiology are there was history of consanguinity, there is a history of previous abortion, uh, the sepsis screen was negative. Now, purpura fulminans can be acquired because of sepsis, but in this case, the sepsis screen was also negative. The blood cultures were also sterile, so that sort of rules out sepsis. And protein C levels were low. Only protein C levels were low. If it was something which was associated with sepsis and full-blown DIC, usually the levels, all three levels would be low. That is protein C, protein S, and antithrombin, all three would be decreased. But here in this case, only isolated protein C levels were low, and protein S, antithrombin 3 levels were normal. So that points that maybe we are dealing with only protein C deficiency, which may be genetic in origin. To confirm the diagnosis, we have to go for a gene analysis, which would show a defect in the PROC gene on chromosome number 2. Again, the management would be supportive. FFP transfusion every 8 to 12 hourly. Anticoagulation may be needed if you have a high D-dimer level. And protein C concentrate is the treatment, but that is not available in India. So for us, it is only FFP transfusion and maybe anticoagulation with heparin. Okay. So I'll move to the next question. Again, one more case-based discussion. So it was a late preterm SGA male child with no asphyxia and no risk factors for sepsis. But the child had respiratory distress since birth. Echo showed PPHN with poor contractility. There was no structural defect. Sepsis screen was negative. On day 4, fever was present with thrombocytopenia and a raised CRP on day 4. And after that, since there was a suspicion of sepsis, blood cultures were sent, but 3 successive blood cultures were sterile. Interleukin 6 and ferritin and D-dimer, all 3 were raised. Uh, then mother and baby, they for both mother and baby, IgG antibody, COVID IgG antibodies were sent, and they were found to be raised with a negative COVID antigen. So in this scenario, with this history, what is the most probable diagnosis? What criteria do we use for labeling the diagnosis? What are the possible treatment options? And which are the 2 systems that are most commonly involved? So I think everybody is coming up with the right answer. So I will go ahead with the answers. Yeah, so the right answer is, as you all said, it is MIS, that is multi-system inflammatory syndrome. The criteria is onset within the first 28 days of life. Either there is fever or involvement of two or more systems. There is lab evidence of raised inflammatory markers, evidence of COVID-19 infection in the form of raised IgG antibodies and negative antigen test, okay, which rules out an active infection. And there is no other alternative diagnosis to explain the features which we are seeing. Again, management includes good supportive care. So if you have PPHN, you have to take care of the PPHN part. If there is respiratory distress, that has to be managed accordingly. And along with that, you have to consider anti-inflammatory therapy in the form of IVIG steroids. And if you have raised D-dimer, there is a chance that it may lead to thrombotic complications. So for that, we need to give heparin. Okay, and the two most commonly involved systems are the cardiovascular and the respiratory system in uh, neonatal miss. Okay, right. So coming to the next question. Yeah. So coming to the last, I think last two questions here. So coming to the statistics, so a study was conducted to study the find the correlation between serum bilirubin values, which were calculated using total serum bilirubin, that is serum estimation and transcutaneous bilirubin, and this was the plot which was generated. Okay, so the questions are: what is the name of this plot? Okay, and when is this plot useful? What are the three horizontal lines which you can see in this plot? What do they signify? And how do you interpret this plot? So I think one person has come up with the right answer. That is good. Anybody else? Okay, I think I'll go ahead with the answers. Yeah, so as somebody rightly said, it is a bland Altman plot, and it is used to study the agreement between two assays which are measuring continuous variable. Okay, so here they are measuring serum bilirubin, which is a continuous variable. Okay, and to see the agreement between the two assays. Okay, uh, so there are three lines. If you see in this plot, there are three lines. So the central line is called the line of bias or the bias line, and the two extremes are called the lines of agreement. Okay, so the central line is called the bias line, and the two lines are called the limits of agreement. And so if you see the central line, if I want to interpret this plot, the central line has a value of minus 1.16, right? So what does this minus 1.16 mean? It means that the value of total serum bilirubin is 1.16 less than TCB on an average. So the average difference between these two would be 1.16. Okay, with TCB value being higher by 1.16, and all the, if you see the plot, all the values here, they lie within the limits of agreement. Okay, so this upper and the lower limits of agreement. So all the values, most of the values, they lie within the limits of agreement. So we can say that there is a good agreement between the two tests. Okay, so TCB may be used as an alternative to TS, total serum bilirubin, for checking bilirubin. Okay. Coming to the last question. So in a study which was done to find the mortality due to NEC, this was the plot that was constructed, okay, which you could see on the right. And so again, the questions are: what is the name of this plot? Okay, what do the horizontal and the vertical arrows, which I have shown here? So what do these horizontal and vertical arrows they signify in this plot? And what is the median survival time? Yeah, so one person has come up with the right answer. Uh, yes. So this is a Kaplan-Meier curve. Okay, and yeah, so this is a Kaplan-Meier curve. The horizontal line, it shows the survival probability at any given point of time, and the vertical line, it shows the occurrence of the event. Okay, So this horizontal line, see, basically it is a graph of time in hours against the survival probability. Survival probability is on the y-axis. So if I ask to interpret this vertical line, it indicates what is the survival probability at this time. Okay. So at 20 hours, what is the survival probability? That is around 0.75. At 30 hours, what is the survival probability? That is somewhere 0.6. Okay. So the horizontal line indicates the survival probability, whereas the vertical line, this vertical drop, it indicates the occurrence of event. So that here it is the mortality or death which we are dealing. Okay. And the last question is, what is the median survival time? So it is basically, if you see the graph, we have a line drawn here. Okay. So it is median survival time is time is here on the x-axis. So that time at which the probability of survival is 50%. Okay. So you have to draw a dotted line from here and here. So it is somewhere around 36 or 37 hours. Okay. Right. So I think with this we can end the discussion. If there are any questions, I'll be happy to take. Else we can wind up the session. Okay, ninth question. One second. Any other questions?
Yeah, let's move it. Good night.
Okay.
It's already 10:17.
Yes. Yes, sir. Yes, sir.
You put almost
think we
40
can
OSCE rather than 10.
Sir, I thank Dr. Ashish Mehta sir and Dr. Sandeep Tinwali for excellently moderating the session. Our students were great also in answering. I think we have done enough time and given enough time for them also. So I think good night, and we are closing the session.
Thank you. Good night. Thanks a lot.
Thank you, everyone.
Good night. Good night.
Good night, sir.
Good night.